learned, they begin to take people to court. They want you to come and justify what happened to my baby. Maybe at the end of the day, the doctor can save himself, and you as a midwife will be stranded. We say anything that is done and not reported was never done.
You're telling me to give you the file of the patient that was convulsing. What if that patient had died?
We need to sit down and then discuss all of this to make them understand the place of a midwife and where the doctor comes in.
It was like, you people will not come here and confuse me with big book. Let me tell you, I have worked even with nurse assistants, and I think they even do better than you do. It is not because you have a master's in midwifery or degree in midwifery that you think you come here and you're working with emotions.
Hello everyone, welcome to another episode of Africa Health Insight. As usual, I'm your host, Steven Elvis. In today's episode, we want to look at the dynamics of the healthcare team. I have with me, to my right,
Tosi Jones, midwife.
And
I'm called Judith, a midwife.
It's a pleasure to have you. Judith, can you share with us your experiences you've had to work with medical doctors in order to deliver care to our clients as a midwife?
Thank you, Elvis, for that wonderful question and for this opportunity. We have so many wonderful doctors out there, but it doesn't cancel the fact that we equally do work with doctors who come with their own different opinions, and they just want to impose on us and want us to work exactly the way they want us to. So I'll be talking about an 18-year-old primate that was admitted in the ward for follow-up. There was this emergency surgery which we had to do in the theater, and after that I was called to come and review a patient in the ward. So when I went, this client was convulsing. So I immediately rushed back to the theater to inform the doctor, telling him that he should hurry up and finish with what he's doing, and then come to the ward because there is a patient there he needs to see. I was surprised that when he left the theater, instead of him coming straight to the ward, he went and sat in the nurse's station. And I was like, Doc, I told you this patient is convulsing. What are you doing in the office? He told me he's not putting on his jacket, so he cannot go to the ward because of that. I should go to the ward and bring that patient to the office. And I said, but how can I go to the ward and bring a patient who is convulsing to the office? Since we were at loggerheads, I just looked at him and then I left. When I left, I went back to the ward thinking he was going to follow me, but unfortunately he didn't. I went out to the ward and just tried to reposition the patient, remove every pin or anything around that patient which I think could harm her, then try to monitor the vital signs and so on. All of a sudden now, she stopped, because I would say it was God. She stopped convulsing, came back to the office, and that doctor was seated there. When I came, I did not tell him anything. I just came and sat quiet. So when he sat down for some time, he got up now and said, let me go to the ward and see the patient you're talking about. So when he left, I did not follow. I stayed back in the office. So when he entered the ward now, he could not identify who was convulsing and who wasn't. So he came back now to the office and said, I should give him the file of the patient that was convulsing. So out of anger now, I just said, you're telling me to give you the file of the patient that was convulsing. What if that patient had died? What would you have said? You would have said, is it because you're not putting on your jacket? Now that you went to the ward, are you putting on your jacket? That was what I asked him. So when I asked him now, he got angry and he told me that if I have any case in the night, I should not call for him because he was not going to respond to my call. So when he left now, I sat on my own and I was thinking. I was just asking myself questions. If I stay quiet now and something happens, what will I do? I will be held responsible because I was the staff on duty. Now, if I call the head of the institution to say that this is what has happened, it will look like I am reporting him. So what am I going to do? This idea just came to me that I should contact one of the elderly nurses. It was an anesthetist that was there, and then I tell him what has happened. So I went to him and then explained everything, and he just told me that he's happy I came to him. I should just call the director and explain to him, because at that moment that client, she never had her drugs. Yes, she didn't buy her drugs, saying that she's waiting for her carer to come and buy. So I should just call the director and explain to him that this is the situation, the client is convulsing. I'm pleading if I could go to the pharmacy, collect those medications, and then the carers come and pay later on. So when I went and presented the case now to the director, the first question he asked me was, where is the doctor on call? I had no other option than to tell him what had happened. So I just told him that we had a clash because of this. And when I explained, he just said, okay, go to the pharmacy, collect the medications and sell it.
Now, Jones, I want to know, do you think the reaction from Judy, could she have reacted differently to make sure that the team addresses the patient in question and she suppresses her emotions? Because at one point in time, I think she kind of shouted at the medical doctor. Do you think she could have reacted differently? And if you were in that position, what could you have done?
It's somehow challenging, and until you find yourself in that situation, you will not really know what to do. But I think that as healthcare professionals, our goal is to have a healthy patient, especially when it comes to maternity. Our goal is to have a healthy mother and a healthy baby. And sometimes, even faced with these challenges, we just have to calm ourselves down and make sure that we give the care that we are supposed to give, and then see how to sort ourselves at the end. So, but at least it's good that despite the fact that she reacted the way she reacted, she didn't just stay there. She went ahead to talk with someone else and also get to the director to get a solution to the problem. So for me, I think it wasn't bad.
This type of reaction, if we are thinking about the patient at the forefront of the care that we give, don't you think our differences should instead enhance the care that we give to our patients? Like, where do you think this comes from?
For me, also based on my experience, I think that especially when it comes to midwifery, there's something that most medical doctors they are yet to understand, especially those just leaving school, based on my experiences. Yes, because they feel that you as a midwife giving an idea about a woman, you want to show that they don't know, and so on and so forth. But I think we need to sit down and then discuss all of this to make them understand the place of a midwife and where the doctor comes in. Because I've seen cases where we have lost babies because the doctor too did not want to listen to the midwife, and at the end the patient suffers. So there is a lot that we have to do as far as talking to doctors concerning pregnant women and labor and all of that. So I think that's where we have to go back and begin to tell that this is the place of a midwife. This is what she's supposed to do, and sometimes it is necessary to give a listening ear because most often they don't listen.
Are we in a situation where people's egos are playing within the healthcare team in such a way that we do not put the concept of emergency management, critical care at the forefront of our care? Is it that most people are not trained on this?
I think it's vital, and most often we cannot conclude that maybe they don't incorporate it in the training, because most often, so when you look at nurses, some midwives, the way they act on the field, you ask yourself, were they actually trained? Because when you look at the medical field, there's ethics. There's medical ethics. They are trained on that, but now, like you said, people have their personal egos. And especially when you leave school, you feel like you have not experienced a lot, because a medical doctor who has experienced a lot of challenges when it comes to maternity, it humbles them. And because of that, they are able now to give a listening ear to team members. It's not only midwife, but to any other person that has to play a part in that team. We need to really take a lot of time, even after training and while working, we begin to educate ourselves on the importance of each person as part of a team member or as a team member.
Can you share with us another story that you've had, or a similar situation that you've had?
A multi that has been in active labor.
When you say a multi, do you mean somebody who has?
Someone that has delivered like 5 times and above.
Okay, thank you. Go ahead.
We can even call her a grand multi.
Okay, thank you.
She has been in active labor like 8 to 10 hours. Active labor, let's just say labor is somehow divided into stages, and whereby we have the first stage of labor, and that first stage of labor is always divided into two phases. The first stage has two phases, which is the latent phase and the active phase. The latent phase of labor, most times when the midwife will assess, and then we check for cervical dilatation and we check for contractions. Yes, so mostly in the latent phase of labor, you have the cervical dilatation between 0 to 4 centimeters dilatation, and at that moment, the contractions are still, we cannot say weak or mild, as some people put it. But now, when someone gets into the active phase of labor, and that person has gotten already from 5 centimeters dilatation and has at least 2 moderate contractions and above. So for this particular parturiente, and let me say a parturiente is a woman who is in labor, that's how we call them. She has been in that active phase of labor for over 8 to 10 hours already, and I can say she was already like 8 centimeters dilated. So to us, it is a problem. We follow women using pathographs, and they have a certain point in it whereby when it reaches, action is supposed to be taken. And when you are looking at that pathograph, the action line was touched and had passed. So we saw that, okay, it is now time for the doctor to come and review and then give orders for us to go ahead. And that we think that the action to be taken at that time was augmentation. But to the doctor, when he came and then we presented everything, he said we should be stripping. Now we ask ourselves, someone is already at 8 centimeters dilatation and has been there for over hours. What are we stripping? Membranes have ruptured. When you rupture like that, it predisposes that child already to early neonatal infection. And even that woman might have endometritis at the end of the day. So to us, augmenting will help that labor to progress faster, thereby preventing all those things. So when we're saying that this woman has been in labor and we're presenting all those other risk factors, and even the fact that she could end up presenting with postpartum hemorrhage, it was like, you people will not come here and confuse me with big book. Let me tell you, I have worked even with nurse assistants, and I think they even do better than you do. It is not because you have a master's in midwifery or degree in midwifery that you think you come here and you're working with emotions. And we were like, isn't that all these things we have presented do not ring a bell to his head? Or what we are saying, is it out of midwifery? Because we were like confused. But after we had argued and argued, we just said, okay, let's respect what he has said. And we did what he said we should strip, because truly speaking, stripping at 8 centimeters, we did not see it necessary. So that woman stayed like that, and maybe 2 hours later, fetal distress now set in. That augmentation at that time was no longer necessary, for that woman was now taken into the theater for a cesarean section. During that cesarean section, she presented with postpartum hemorrhage. And after that, that baby presented with early neonatal infection. And she now, during the postpartum period, she started presenting with some signs of endometritis. When you look at that particular scenario, we just want to say, had it been he listened to us, maybe all those things would have been prevented.
I don't know, in your practice, in midwifery practice, is it permitted at that particular point, looking at the risk to the mother and the baby? What are the policies? What are the recommendations? I'm not sure if there are some policies talking about this type of scenarios, but in that particular case, can you as a midwife augment without the orders of the medical doctor?
So the answer to that question is no.
It's no.
Because he is the operator. Augmentation has its disadvantages. If you augment, indirect fetal distress might come in. There might be an emergency, maybe a uterine pre-rupture sign or something, and you'll be needing his attention immediately. So if we are at loggerheads, at that moment now, it will be like, I told you not to. So just buying some small time on our part, yes, we could just respect that his own. Since we had listed all the risk factors and the rest, at least we could still give that small time before we call in now for other opinions to be coming in.
But I want to know from you, what is your take on this particular scenario?
It's just in line even with the first one, and truth be told, this is what midwives and other healthcare professionals they face on a daily basis. And it's saddening that at the end of the day, we end up losing babies and even mothers just because of these differences. So I really think, like we said, begin to hold meetings, have such discussions so that people understand. Because at the end of the day, what happens is that the woman will lose her life. And then even if the doctor, you are sorry at the end, we cannot turn the hand of the clock.
Exactly.
So I think that we really need to, health provision is all about, it's about teamwork. It's not about each person wanting to show that the person knows more than the other. So most of all, we really need to leave our egos and then begin to listen and work as a team. Any person in the team can contribute. So I think that we really need to begin to hold such discussions even in our different facilities. Yes.
And something I find fascinating in our case settings is the lack of documentation to most of these cases. Like, if we want to track back to see exactly what happened, how do we learn? How do we improve in the future? We can only improve from the precedent, what had happened in the past. But now, do we have those facts to say that this is what happened? Have we been able to document all these cases? What do you think we can do in this line?
Yeah, I think that documentation is very important. It's vital, but it's often neglected. And most often we say anything that is done and not reported was never done. I've worked in two different systems. Let me just say with the CBC, I've seen they do a lot of documentation. Like what they do, each step you take, you must write down. Doctor was called at this time. This. But in other places, we don't do it. And I think that for us to also solve some of these problems, it's it's vital for us to document everything that we do. And now people are learning. They begin to take people to court. They want you to come and justify what happened to my baby. Maybe at the end of the day, the doctor can sell himself and you as a midwife will be stranded. Like you are saying, we are not documenting because we want to implement somebody. Because you working, because most often the doctor can be the head of the facility. You working under the doctor, documenting that, and the doctor seeing it inside the nursing notes, may feel that you want to implicate him or you want to prove that he doesn't know what he's doing. But it's necessary for us to document all our action. And it goes back to the fact that we need to begin to hold these meetings in our facility, because if you hold them and make the staff know that they are supposed to document everything, and you document at the end, they will not look at you that you did what you were not supposed to do. It will be normal part of practice, and that will serve us a lot.
Thank you once more for being in our platform. Tell us areas that we need improvement in the comment section. Thank you and have a nice day.
Thank you.